Assalamu alaikum, everybody. Welcome to the Shaukat Khanum Cancer Symposium, Nuclear Medicine and Molecular Imaging session. Excuse my voice. I think it's the environment that's it's a little fluey. We are honored today to be joined by respected faculty from around Pakistan as well as internationally. It is a pleasure to welcome you all here, and we hope today's session will be an intellectually stimulating session for all of us. The focus today is more towards theranostics. We'll start with thyroid cancer, age-old stuff that we've always learned, with a new lens on it. And then we'll move forward towards more cutting-edge stuff, lutetium therapy, gallium imaging, etc. But first, I would like to introduce my co-moderator, Dr. Akhtar Ahmed. Dr. Akhtar has joined us from Kiran, respected faculty member in nuclear medicine, Dean of Nuclear Medicine, senior physician. It is an honor for us to have him, sir, if you would join us. So we'll start our first presentation with Dr. Arzu Fatma. Dr. Arzu is joining us from Inmol Hospital. Dr. Arzu has a passion towards thyroid cancer and all the nuances, all the guidelines, etc. So we're hoping and we're looking forward to a wonderful talk from her about management of differentiated thyroid cancer, a practical approach as she looks towards cases, guidelines, etc. Dr. Arzu.
Thank you so much, Amna. It was such a beautiful introduction. This is a passion that I've discovered just recently. So let's hope that you people enjoy the cases that I'll be presenting. And a good morning to all of you present here. And it's heartening now to see the hall gradually filling up. Otherwise, I thought that maybe I will be giving this talk to myself only. Okay, so let's begin. Well, as Dr. Amna said, that today's session is about theranostics. And as you all know, that the concept of combining diagnosis with therapy has existed for the past 8 decades, with the use of iodine for thyroid diseases being introduced in 1941. However, it was not until 2002 that the term theranostics was created to sort of, define or label this system. So I will be presenting right now a few interesting cases of differentiated thyroid cancer. And they will be covering the usual clinical scenarios, including a pediatric patient, a patient with a diffuse lung mets, a patient who has undergone lobectomy for follicular neoplasm, and a patient having coexistent anaplastic and papillary cancer, and a patient presenting with NIF-TIP. So my primary focus will be upon the management decisions of these patients according to the commonly used guidelines. 2015 ATA guidelines, NCCN version 3.2, guidelines that were published in October 21, SNM and ENM guidelines, and these were published recently, that is the abbreviated version, in June 22. ESMO pocket guidelines published very recently after the ESMO meeting in September 22. So in each case of thyroid cancer, one needs to make 5 important decisions. Number 1, post-operative risk stratification. That is, you need to risk stratify the patient as to whether he or she is at a low, intermediate, or high risk of recurrence. Next comes the decision whether to give radioactive iodine therapy or not. If yes, what dose to give, how much TSH suppression is required, and what investigations should be conducted in the follow-up. So let's begin with the cases in the light of the guidelines. Case number 1, 15-year-old female patient presented with a nodule in the right lobe of thyroid. Her FNAC showed Bethesda category 5 or suspicious for malignancy with an implied cancer risk of 45 to 60%. The recommended management in this case is near total thyroidectomy or lobectomy. So this patient underwent total thyroidectomy and right neck dissection. Her histopath revealed an aggressive variant of papillary thyroid cancer, that is diffuse sclerosing variant. Tumor size was 2 centimeters. Extra thyroidal extension was grossly positive, and 16 lymph nodes were involved. Her post-op investigations at 4 weeks were all quite unremarkable. This is the diagnostic iodine whole body scan showing normal physiological tracer uptake. However, upon risk stratification, according to the ATA 2009 risk stratification system, she came out to be high risk because she has gross extrathyroidal extension. So the next question is whether to give radioactive iodine therapy or not. Radioactive iodine is typically recommended in her case in accordance with the NCCN guidelines because she has gross extrathyroidal extension and she has more than 5 positive lymph nodes. The next question, what dose to give? Well, the patient has no evidence of persistent locoregional disease or distant mets, but she has a high risk of recurrence. Therefore, adjuvant therapy, that is 50 to 100 millicuries, would be recommended according to the SNM ENM guidelines. And the recommended pediatric dose that you can see on this flow chart in the extreme left-hand corner is 2.15 millicuries per kg of the body weight. So this patient was administered 80 millicuries of radioactive iodine according to her body weight. Next, she was put on thyroxine with a view to obtain a strong suppression of TSH, that is levels below 0.1, according to both NCCN and ATA 2015 recommendations for high-risk patients. What would be the follow-up plan for this patient at 6 monthly intervals? Tumor markers, ultrasound neck, and iodine whole body scan in this case because she has a high risk of recurrence. So the teaching points in this case, mortality. Age is the most important variable for thyroid cancer mortality. And the mortality rate increases dramatically after 60 years. Tumor recurrence, however, shows a remarkably different behavior with respect to age, and the recurrence rate is highest for those who are less than 20 years or more than 60 years of age. This means that both mortality and recurrence show different behavior in younger age, but both become very high after 60 years of age. Case number 2, this is the patient with lung mets. 29-year-old female patient presented with swelling in neck for the past 6 months. She underwent total thyroidectomy and bilateral neck dissection. Histopath revealed a papillary carcinoma 8.5 centimeters in size involving both lobes and isthmus. 24 lymph nodes were involved and the size of the largest nodal deposit was 3 centimeters. Her TG levels at 6 weeks were markedly elevated. Ultrasound neck, however, showed thyroid remnant only. But the iodine whole body scan revealed the source of the thyroglobulin, that is tracer avid diffuse bilateral pulmonary metastases. CT chest confirmed these findings, showing innumerable bilateral pulmonary nodules. She came out to be high risk because she has distant mets, she has post-op TG levels suggestive of distant mets, and she has a metastatic lymph node that is 3 centimeters in size. So radioiodine is typically recommended in her case because, again, referring to the recommendations from NCCN guidelines, latest version, the patient has, first of all, known distant mets, plus she has a primary tumor more than 4 centimeters in size. She has post-op TG way beyond 10 nanograms, and she has more than 5 positive lymph nodes. As this patient has diffuse distant mets, therefore, she was administered a high dose of radioactive iodine therapy in accordance with the recommendations of SNM EANM guidelines. And she was then put on thyroxine with a view to obtain a strong suppression of TSH. Her follow-up will also include tumor markers, ultrasound neck, and iodine whole body scan, as she is high risk, plus she has previous tracer avid pulmonary mets. So the teaching points in her case is that pulmonary micromets should be treated with radioactive iodine therapy, and the therapy should be repeated every 6 to 12 months because these mets show the highest rates of complete remission. However, in the case of macronodular mets, complete remission is quite uncommon. Pulmonary pneumonitis and fibrosis are rare complications of high-dose therapy. If they do occur, then further radioactive iodine therapy should be stopped. Case number 3, a patient who underwent lobectomy for follicular neoplasm, 29-year-old female patient having 1-year history of anterior neck swelling. Her previous investigations were as follows. Ultrasound neck showed a multinodular goiter. Thyroid scan showed a cold nodule in the right lobe, and FNAC revealed follicular neoplasm. She underwent right lobectomy and isthmusectomy. Now let us look at the indications for lobectomy or a bilateral procedure, that is total thyroidectomy, if all criteria are present. There should be no prior radiation exposure, no distant mets, no lateral cervical lymph nodes, no extrathyroidal extension, and tumor size should be between 1 to 4 centimeters. The histopath of this patient showed classic papillary carcinoma, 2.3 centimeters in size. Her investigations at 4 weeks of surgery, ultrasound neck showed an unremarkable left lobe, plus a few benign looking lymph nodes. Stimulated anti-TG, however, was elevated, and the iodine whole body scan revealed a thyroid remnant only. What next? Well, 3 options are usually available, and so is the case after lobectomy. Should we go for completion thyroidectomy, or radioactive iodine therapy, or active surveillance? Well, completion thyroidectomy is recommended if any of the following risk factors are present: large tumor size more than 4 centimeters, gross positive resection margins, gross extrathyroidal extension, confirmed nodal mets, confirmed contralateral disease, vascular invasion, poorly differentiated disease, lymphatic invasion, and macroscopic multifocal disease. None of these were present in the case of this patient. So the option of completion thyroidectomy is out. Number 2 option, radioactive iodine therapy following lobectomy. Well, the NCCN panel does not recommend it due to lack of data showing benefit. However, thyroxine may be considered to keep TSH levels to low or low normal level. That is between 0.5 to 2.0. The third option is active surveillance with tumor markers. Now, this patient had her anti-TG levels depleted after another 6 weeks, and as you can see, there's a further rise. Her ultrasound neck at the time was quite unremarkable. Queries in this case: what should be the next plan of action with rising anti-TG levels? Well, surveillance with tumor markers and periodic neck ultrasound would be the best course of action till there is structural evidence of disease. What TG, anti-TG levels would be considered actionable after lobectomy? While specific cutoffs of TG that distinguish normal residual thyroid tissue from persistent thyroid cancer are unknown in post-lobectomy cases, rising TG levels over time, mind you, this means a rising trend, are suspicious for growing thyroid tissue or cancer. The significance of elevated or rising anti-TG levels, however, in post-lobectomy cases is not very clear, as is the case with this particular patient. Okay, are rising anti-TG levels an indication for completion thyroidectomy? No, they're not a criteria for completion thyroidectomy, according to the NCCN guidelines version 3.2. Well, these anti-TG antibodies occur in approximately 25% of thyroid cancer patients and 10% of the general population. When present, they will falsely lower the TG levels in immunometric assays. They may serve as an imprecise surrogate marker of residual normal thyroid tissue, Hashimoto thyroiditis, or tumor. Their transient rise may be seen after surgery and ablation. They should disappear around 1 to 3 years, and their new appearance or rising titers are associated with an increased risk of recurrence or persistent disease. Case number 4. Now, this is rather an interesting case, and I request all of those who are dealing with DTC to kindly look at it carefully, because this is a patient who has coexistent anaplastic and papillary carcinoma. This was a 50-year-old patient, had history of swelling neck that was present for the past 10 years, but increased rapidly in size over 1 month. She underwent subtotal thyroidectomy. Her histopath revealed an anaplastic cancer in the background of papillary cancer, with the anaplastic component being 20%. Tumor was unifocal, involving the right lobe and isthmus, 5.5 centimeters in size. Margins were involved, ETE was present, and there was involvement of strap muscles. Post-op CT showed a solid cystic lesion involving the left lobe, plus a few small volume lymph nodes. So at this stage, you can see that there's nothing really very alarming. The anti-TG levels were, however, again elevated. This is the iodine whole body scan at 4 weeks of surgery. And the only thing you can appreciate is intense focal uptake in the thyroid gland. However, by then, that is after 8 weeks of surgery, the patient had developed marked right neck swelling. She was sent for surgical opinion and redo surgery. She underwent excision of right neck lesion and resection of nodules, revealing poorly differentiated carcinoma infiltrating the skeletal muscles and fat. So the queries in this case, what would be the further treatment plan for this patient, keeping in mind the 2 histopath reports? As we all know that anaplastic and poorly differentiated thyroid cancer, both are rare, but very aggressive types. Both take origin from follicular cells, both have a very poor prognosis, survival for anaplastic being few months, and for poorly differentiated being few years. Treatment in the case of both is mostly palliative and limited to surgery for resectable disease, with adjuvant radiotherapy, that is EBRT, and chemo, the only other options if the cancer is persistent or recurrent after surgery. How soon after surgery EBRT can be given? Maybe after 4 to 6 weeks. Is there any role for radioactive iodine therapy? Considering the 80% papillary component, yes, it may be considered if there is evidence of radioiodine avid disease, which in this case, as you could see in the post-therapy, the diagnostic scan, there was a focus. So the patient was administered high dose of radioactive iodine therapy under steroid cover. And the post-therapy scan on day 10 showed intense focal uptake in the thyroid bed. Unfortunately for this patient, few days after high-dose therapy, the patient presented in our OPD with marked neck swelling and stridor. Now here's a question for all of you, because she was given a very high dose. It could have been radiation thyroiditis or a rapidly progressing recurrent anaplastic cancer. So let us have a look at her investigations. Ultrasound neck done at the time showed multiple lesions in the left lobe, as well as the surgical bed, and there were multi-level enlarged metastatic nodes. Thyroid scan with SPECT-CT was also conducting at around the same time, and it showed similar findings. As you can see in these images, there is a tracer avid nodule in the left lobe of the thyroid. There are multiple tracer non-avid nodal masses, with one infiltrating the left sternocleidomastoid muscle. This patient had by now become very dyspneic, and so she underwent tracheostomy the very next day. Further treatment plan can only be palliative EBRT plus minus low dose chemo. So an important teaching point in this case is it may have been better to administer EBRT earlier, though the course of anaplastic carcinoma is unfortunately still very rapid and the patient's survival very poor. This is the last case, a young female patient who was diagnosed to have NIFTIP after surgery. She was 26-year-old. She presented with history of anterior neck swelling since the past few months, and the thyroid scan revealed a cold nodule in the left lobe of thyroid. She underwent total thyroidectomy. Her histopath revealed an encapsulated follicular variant of papillary carcinoma, which is now called NIFTIP. The tumor was bifocal, involving both lobes, and the tumor size in the right lobe was 3 centimeters. Follow-up investigations at 2 to 4 months, tumor markers were unremarkable, except that, of course, the TSH levels, as she had undergone total thyroidectomy, were more than 50. Ultrasound neck showed residual thyroid tissue plus few benign-looking lymph nodes. She was put on thyroxine replacement therapy. Now, the follow-up in the case of NIFTIP is just tumor markers and periodic neck ultrasound for at least 2 to 3 years. What does NIFTIP stand for? Non-invasive follicular thyroid neoplasm with papillary-like nuclear features. Mind you, it is just going to have papillary-like nuclear features, but it is going to show a follicular growth pattern. So papillary-like nuclear features means a typical term that is used to describe it is called the orphan anenuclei, which means that the chromatin, which is normally uniformly dispersed in the nucleus, becomes marginalized, and the membrane of the nucleus shows pseudo invaginations or inclusions. So this is characterized by a follicular growth pattern. It must be encapsulated, and it should have nuclear features of papillary carcinoma. Now, these tumors have a very low risk for adverse outcomes, and therefore they require less aggressive treatment. Why the name change to NIFTIP? In 2016, NIFTIP was reclassified to prevent overtreatment of this indolent tumor type, as well as the psychological consequences associated with cancer diagnosis upon the patient. The recommended management is only lobectomy or thyroidectomy, and that is all. No need for radioactive iodine ablation or TSH suppression. So why is there a need for at least a follow-up of 2 to 3 years? Well, in literature, there have been reports of lymph node mets and 1 to 2 cases of bone metastases. The diagnosis of NIFTIP requires a very stringent criteria. I don't think I'll be going into the details. And I believe that should be all as far as the cases are concerned. Well, I'm pretty positive that by now, at least some of us are quite clear about the take-home messages. But just to summarize, risk stratification is very important in each case. Radioactive iodine therapy is not required in all the cases. No dose or low dose may be considered in low to intermediate risk patients. TSH should not be suppressed below 0.1 in all the patients, and iodine whole body scan is not required in the follow-up of all patients. There is just one last thing that I would like to share with you pertaining to my passion, as Dr. Amna said, for DTC. Very recently, I have compiled a summary of all these guidelines in the form of a book. And this is the title page of my book. It has got 8 sections. The first section comprises of about 200 MCQs, and they will cover the entire spectrum from the thyroid nodule to the very advanced radioiodine refractory thyroid cancer. These will be followed by all the guidelines, and the last section has a long list of interesting cases from InMol archives. So this book is currently under publication, and inshallah, hopefully in the very near future, it should be available. Thank you very much.
Thank you, Doctor. Our next speaker is our invited guest, Dr. Saima Muzahir, and she is consultant nuclear medicine at Emory Medical Center, Atlanta, USA. She has been affiliated with Shaukat Khanum, and it's good to have her back. And her topic is real-world use of PSMA therapy, current landscape, and future outlook. Thank you.
Thank you very much, Dr. Akhtar. It is my absolute pleasure and honor to be present here for the SKM Symposium. And Assalamu alaikum to all of you. So today I'm going to talk about the real world use of PSMA therapy. How is the current landscape looking like, and how the future holds for us. I do not have any conflicts of interest. A brief overview of what we are going to cover today. Introduction. What are the standardized criteria in the PSMA PET-CT for selection, patient selection for lutetium PSMA radioligand therapy? What are the prognostic factors which affect outcome after lutetium PSMA therapy? And this includes nomograms to assist during the patient selection process. Contributing factors to resistance to PSMA therapy, and combining PSMA radioligand therapy with potentially synergistic agents. So let's start. So we all know that prostate cancer, it's a continuum, and the metastatic castrate-resistant prostate cancer, abbreviated as mCRPC, and that's the word I'd be using later on in the talk, represents the last phase of the prostate cancer continuum and continues to be fatal disease. It severely impacts the quality of life, and the 5-year survival rate falls to a dismal of less than 30%. So let's look at the contemporary prostate cancer states and the systemic treatments which are available. As you can see in this graph, the pathogenesis of the prostate cancer, it starts with the hormone-sensitive state and then continues into the more aggressive advanced stage, which is the castrate-resistant. And for the early stage, which is the clinically localized state, we have active surveillance, we have surgery and radiation. And for non-metastatic hormone-sensitive space, we do have observation, intermittent ADT, and salvage treatment. And PSA is used as a tumor marker. It not only enables tracking of disease should initial therapy fail or maybe subsequent lines of treatment fail. Now, the therapeutic options that we have for the CRPC. So in the first half of 2010s, there was an unprecedented progress in the treatment of mCRPC, and with the addition of new 4 survival prolonging drugs, and these are abiraterone, cabazitaxel, enzalutamide, and radium. And we as nuclear physicians have to be very knowledgeable about these different treatment options that are available out there to have a place on the table and to have active part in the decision making when we are making treatment options or decisions for our patients. While in the second half of 2010s, there was unfortunately no positive phase 3 randomized controlled trials, and it seemed that the growth has come to a halt. But in the last decade, there has been an explosion of invention and development of radiopharmaceuticals, not on the prostate world, but throughout different other therapeutic tumors, including neuroendocrine tumors. And the term theranostics, as Dr. Arzu has already very well explained, this term became more widespread and more popular. It's not a new term, but this is the term which is like gaining more popularity and attention. So again, coming to this slide with contemporary prostate cancer state and systemic treatment options, we'll focus on the metastatic castrate-resistant prostate cancer, and you can see there are multiple treatment options available. You can see this slide is from 2020, and you see radium-223 as the only radionuclide therapy available at this point in time. And then if we look more closely about these different drugs, so what do we have? So we have hormone therapy in the form of abiraterone and zalutamide. We have chemotherapy in the form of docetaxel, cabazitaxel. We have PARP inhibitors in patients who have BRCA1, BRCA2 mutations. We have immune therapy, we have vaccines, and we have radiotherapy as well. In 2018, at the annual SNMMI meeting, this was the image of the year. This looked too good to be true. This was, the image was courtesy of Dr. Hoffman and his colleagues from Australia, and the image shows PSMA PET-CT before and after 3 months of lutetium PSMA therapy in 8 patients, before and after lutetium PSMA therapy, and you can see dramatic response being shown in this. And while the world was still pondering whether it's real, whether we'll move, within 4 years, here we have FDA approved the first targeted radioligand therapy for the treatment of progressive PSMA positive metastatic CRPC. And this indeed is a step forward in the evolution of precision medicine. And the trade name for lutetium PSMA therapy, which was coined by Novartis, is Pluvicto. So it's administered every 6 weeks, up to 6 treatments, with a standard dose of 200 millicurie every 6 weeks for up to 6 treatments, or until disease progression or unacceptable toxicity. So what led to the FDA approval of lutetium PSMA? Of course, this groundbreaking international multi-center phase 3 trial, the VISION trial, which all of you guys must be familiar with. And this was a randomized trial, and what they did in the trial was they enrolled patients who had advanced metastatic MCRPC, and they had already progressed on hormone therapy and at least 1 or 2 taxane-based therapies. So these patients were randomized into 2:1. Patients either received Lu-PSMA therapy every 6 weeks for 6 cycles, plus standard of care versus standard of care alone. And the results were very promising. As you can see, the study showed that Lu-PSMA prolonged imaging-based progression-free survival 8.7 months versus 3.4 months in the standard of care arm, increased the overall survival 15 months versus 11 months in the standard of care, and significant improvement in time to first symptomatic skeletal events. So VISION trial results were published in 2021. In the same time period in Lancet, this was another trial which was published, which was a therapy trial. This was a multi-center unblinded randomized phase 2 trial. And this was performed in 11 centers in Australia. And again, they recruited patients who were metastatic castrate-resistant prostate cancer patients and whom cabazitaxel was being considered as the next appropriate standard treatment. So the eligibility criteria, again, were all these patients underwent PSMA PET-CT and FDG scan, and they had metastatic lesions, which showed significant PSMA uptake higher than liver. And the primary endpoint for this study was a significant drop in PSA from the baseline, that is more than 50%. And the study clearly showed that Lu-PSMA is a very promising treatment, and it showed significant response in the lutetium PSMA arm versus the cabazitaxel. Response rates were also great, and so it was better tolerated with less toxicity profile compared to cabazitaxel. Let's look at the VISION trial and the therapy trial side by side. So if we look at the eligibility criteria, there's a slight difference in the eligibility criteria. So the VISION trial only used gallium-68 PSMA PET-CT as the screening or gatekeeper test. Whereas the therapy trial, in my opinion, is a better tailored trial because they included both gallium PSMA PET-CT and FDG PET-CT as gatekeepers or identifying eligibility before the patients could be enrolled in the treatment. But again, both the trials showed significant improvement in progression-free survival and PSA response rates. Recently, actually, this slide is from 2021. So recently, the therapy people, the Dr. Hoffman and his colleagues in ASCO this year, published overall survival after follow-up of 3 years, and they showed that there was no significant difference in the overall survival in patients who received lutetium PSMA versus the cabazitaxel group. But given the significant drop in PSA, quality of life, less toxicity, they promoted that lutetium is a suitable option. And this is, at the moment, lutetium PSMA is considered as a third-line treatment option for mCRPC patients. So looking at this slide, so if we focus on this castrate-resistant prostate cancer phase, we have the chemotherapies, hormone therapies, and now with the therapy trial and the VISION trial under our belt, now we have lutetium PSMA therapy. So what exactly is PSMA? It's a type 2 transmembrane glycoprotein, and it's overexpressed dramatically in malignant prostatic tissues. And PSMA and theranostics, we know PSMA has emerged as a very attractive target for theranostics. And the PSMA radioligands are internalized after binding to the target, enabling delivery of radiation directly into the malignant cells. So here is the gallium PSMA PET-CT, and this is the diagnostic component of the theranostic or the diagnostic pair of the theranostics, and this is the therapy component, which is the loop PSMA therapy, delivering beta radiations which cause single-stranded breaks in the tumor DNA. Moving forward, what are the practical applications that we need to know? We know there is a therapy, but what are the practical applications here? So for the practical application, I think the most important thing to understand is what are the different models to prognosticate outcome after PSMA-based radionuclide therapy to have better patient outcome. And when we talk about personalized medicine, these things should be incorporated in our clinical practice and decision making. So the clinical parameters to look at is the initial diagnosis of prostate cancer, the histopathology, the treatment history of the patient, the baseline clinical status or the performance status, and the lab values. Sorry, I don't know why this is twice. So this was a study published in 2020. This was a retrospective study analyzing 52 patients who were treated with lutetium PSMA, which was given as an off trial to men with mCRPC. And they identified clinical factors associated with the PSA response. So what they found was that there was a significant negative association between the number of previous chemotherapy lines and a PSA decline of 20. They also noted that older age, higher hemoglobin, and lower baseline alkaline phosphatase were each positively associated with a PSA decline of more than 20% in univariate analysis. And any PSA decline of at least 10% or at least 20% at PSA nadir is associated with survival benefit. So that's quite promising. This is another study which was published in 2021, and this was a multi-center retrospective study. It screened patients with mCRPC who had received LU-PSMA between December 2014 to July 2019. And what they were looking at here is predictors were included in the nomograms, which were timed since initial diagnosis of prostate cancer, chemotherapy status, baseline hemoglobin, gallium-68 PSMA PET-CT parameters, and the primary outcomes for the nomograms were overall survival and PSA progression-free survival. So what we learned from this study was what was associated with worse outcome after LU-PSMA, shorter time since the diagnosis of prostate cancer, previous treatment with taxanes, low hemoglobin concentrations to start off with, poor performance status, and need for pain medication at the treatment initiation. So these were all bad actors. Moving forward, what are the key players in the imaging characteristics that we have to keep in mind when we offer this treatment for our patients? Well, these are low or whole body tumor PSA expression as associated by mean SUV value, low number of PSA positive tumor lesions, that is less than 20, bone and liver metastases. These are all associated with worse, shorter overall survival. PSMA PET CT, that's the gatekeeper. That's the first thing that we do to identify patients who would be eligible for this treatment. And this was used both in vision and therapy trial using liver as a reference. So looking at this image, so look at this lesion with a yellow circle around it. That's a rib lesion with uptake significantly higher than liver. And so by vision, this is a PET positive lesion. Whereas this left lower lobe nodule, which is circled by this red circle, doesn't have an uptake or very minimal uptake, which is less than liver. So by vision criteria, this is a screen failure, like this lesion is not. So they'll measure this lesion based on RECIST 1.1 criteria. And do we really need PSA positive lesions to actually qualify for this therapy? Because about 13 to 17% of patients in the vision didn't have enough PSMA expression. So people wondered, but this is a very interesting study published recently in ASCO 2022. So it was a retrospective study. What they did is they looked at 301 patients who were treated with lutetium PSMA and identified patients who would have been PSA screen failure. So out of those 301, they found 29 patients who would have been vision PET screen failures. And out of those 29, 8 had low PSA expression, PSMA expression, and 21 had PSMA negative lesions. And what they noted was that high PSMA uptake on baseline imaging was associated with high rate of PSA response, that is more than 50%. And these two images show the PSA screen failures. Here you see all these lesions, but they have uptake less than liver. So this is a PSMA screen failure versus this patient where this lesion, which is a large lesion in the liver, more than 1 centimeter, but doesn't have uptake. Again, by vision screening criteria, this is a PET failure. So you can predict beforehand that this is the patients who are not going to do well in the long run with this therapy. So what do we learn? PSMA expression is vital. It is associated with favorable outcome. It's associated with longer overall survival, progression-free survival, and likelihood of more than 50% PSA decline. It leads to improved delivery of LU-PSMA to the tumor targets. Prior treatment with radium or androgen receptor signaling pathway is not associated with short or long-term outcome after lutetium PSMA therapy. And the NCCN guidelines, the latest version, also endorse PSMA PET CT as a gatekeeper or as an eligibility criteria for deciding this therapy for these patients. Now, is there a role for dual tracer imaging, FDG and PSMA? We know that absent or low target expression limits the response to PSMA targeted therapies. What is the patient outcome in presence of PSMA negative lesions that can be identified with FDG PET? This was actually explored with those two Australian landmark studies by Dr. Hoffman, the LU-PSMA and therapy trials, because they imaged patients both with gallium-68 PSMA and the FDG PET. And these were the two studies, and they were published in Lancet in 2018 and 2021. And you can see the eligible patients. These are the patients where they have PSMA lesions, which have high uptake, higher than liver. They have FDG lesions, but the lesions are concordant with the PSMA lesions. So these are eligible patients. The other scenario could be no FDG positive lesion and PSMA positive lesions with uptake higher than liver. All the other ones fall under the ineligible criteria. PSMA negative lesions with discordant FDG positive or discordant between the PSMA and FDG. So these are ineligible patients for treatment with lutetium PSMA therapy. And as I said, the PSA response rates from these Australian studies were much higher than the vision trial. And that's likely attributed to the superior patient selection by including FDG PET. So what's the spectrum of PSMA and FDG PET in MCRPC lesion? So we could have three scenarios. One could be patients fall in this category with dominant PSMA expression and very minimal FDG uptake. And for these patients, of course, PSMA radioligand therapy is the primary choice. The other scenario could be this patient population where they have a mix of PSMA and FDG avid lesions. And in these patients, of course, combination therapies, both radionuclide and other chemo and hormone therapies would be helpful. There would certainly be a percentage of patients who would have dominant FDG lesions with minimal or no PSMA avid lesions. And in these lesions, I think non-radioligand therapy will be the mainstay strategy. Next, moving on forwards, what are the different resistance mechanisms that are involved in the PSMA? One has to be mindful, and a little knowledge about them is very helpful, because despite of the promising results of vision and therapy trial, about 30% in vision and 17% in therapy trial patients showed inherent resistance to treatment, and then acquired resistance along is also inevitable. So it's very important to know the mechanisms. So let's dive into them one by one. So failure to deliver a lethal radiation dose leads to resistance to PSMA therapy. Why is that? This could be due to the lack of tumor PSMA expression. This could be due to the neuroendocrine differentiation of the tumor. This could be because of the micrometastasis progression. Why is that? Because the beta length particle, the path length of the beta particle is such that it goes and binds and destroys the larger tumor clusters or the macromolecules. But the micrometastases or small cluster of metastases, they escape ablation. So these micrometastases then present with disease progression, mostly seen in the bone marrow metastases. So how this could be overcome? We can use alpha Auger electrons, which have a shorter length, path length, but they have a high linear energy transfer. So they are more helpful in those dealing with the micrometastases. Another mechanism of resistance to PSMA is distribution of disease or metastases. And we've seen that nodal metastases respond better than osseous metastases. Hepatic metastases don't do very well. They show poor response and inferior survival outcomes. And liver metastases, if they develop after the radioligand therapy, they have low PSMA expression and high metabolic activity, whereas the pulmonary metastases show reasonable response. Another reason to radioresistance is inherent mutations, and the most notorious is P53 mutation, and it's present in up to 43% of prostate cancer tumors, and this has been associated with radioresistance in several in vivo studies. So what can we do? The approaches to enhance PSMA-based radionuclide therapy. Different combination approaches are being explored to have a synergistic agents available out there. One of them is upregulating PSMA expression through androgen receptor targeted agents, increasing tumor radiosensitivity through DNA repair inhibitors or agents causing additional DNA damage, targeting different PSMA binding sites, combining with immune checkpoint inhibitors, chemotherapy, or radionuclide therapy with alpha particles, which target micrometastatic disease. These are just a few of the clinical trials that are underway where they're looking at combining different other chemo or hormone or immune therapies with radionuclide therapies. One of the questions which has been like, people are working on it, can we use lutetium PSMA earlier in the disease course? And there are different studies which are looking for the optimal sequencing of PSMA in prostate cancer early on in the disease course. Lutectomy trial is one, which is evaluating the use of PSMA in the neoadjuvant setting in men with high-risk PSMA positive prostate cancer who are undergoing surgery. We have upfront PSMA addition study trials evaluating the load of PSMA in the metastatic hormone-sensitive space. Or ENZA-P and PSMA4 trials are evaluating radionuclide therapy in early stage mCRPC. So what's next beyond lutetium? Next generation radionuclide therapies. Of course, we have alpha particles, and actinium-225 has shown promising results. It has a physical half-life of 9 days, and early studies have shown good safety profile, low bone marrow toxicity, even in patients with extensive osseous metastases. And the treatment regimens that people have explored is standard fixed doses or de-escalation approach. And this is an example of one of the actinium-225 based therapy in a 69-year-old male MCRPC progressing after docetaxel, treated with 5 cycles of actinium-225, and you can see dramatic response in the disease and then the PSA decline as well. The concept of alpha particles or the utility of alpha particles is not new. Radium-223 dichloride or Xofigo got FDA approval in late 2013, early 2014. It's the first clinically approved alpha emitter. It offers larger improvement in quality of life, reduction in alkaline phosphatase and schedule-related events. The disadvantage is a bone-specific radionuclide, so no effect on soft tissue or circulating components, tumor components. What are the other alpha-targeted therapies? We have actinium-211, bismuth, 13 labeled compounds. This was a recent study which was published in the October issue of the JNM, and this was a treatment outcome and survival using actinium-225 in a series of 53 patients who were progressing after androgen deprivation treatment. And a PSA decline of at least 50% proved the single most important factor predicting progression-free survival and overall survival after actinium. This all seems very exciting, but then there's a lot of logistic and technical issues. The manufacturing of alpha particles is, the radiochemistry is more challenging and all that. So to sum up, screening using theranostic approach, PSMA PET-CT to confirm PSMA positive disease. Addition of FDG PET might be useful, and it may add more therapeutic response in selectively treated patients. But then the clinical utility of adding FDG along with PSMA PET-CT still needs to be sorted out. Predictive factors for outcome should be identified and incorporated in nomograms to assist during the patient selection process. And one has to be knowledgeable of the resistance mechanisms that are out there, which include tumor microenvironment, lower heterogeneous PSMA expression, tumor biological radio resistance, tumor microenvironment. And thank you very much. This is my theranostic team at Emory. Thank you.
Thank you. Thank you, Dr. Saima, for an excellent talk about current practices and a look into the future, which is quite exciting. We're going to move forward towards a virtual talk. This is by Dr. Erin Grady. I believe Dr. Erin has probably joined us online as well. She's going to talk about an overview of lutetium dotatate therapy in neuroendocrine tumors. Dr. Erin is currently at Stanford Medicine. She was a colleague with Dr. Saima at Emory, and prior to that, I've actually worked with her also in Chicago. So it is a pleasure to welcome her for her talk. Thank you.
Hello, my name is Dr. Erin Grady. Very happy to be joining you today and to have been invited to speak at the conference. Thank you very much. Sam, that I'm not here with more persons today as I have attended. I'm very grateful for the invitation among us. I do want to say a brief hello to Dr. Ahmed Hassan for the planning committee and also
So he can break off this cough. You won't notice a thing.
And that's, I won't watch the whole video, but that's kind of a great opportunity to discuss diagnostics, especially with pediatric patients and some of the move on from there. But we can also compare some of our prior imaging with the 3D scans with dopamine imaging today. And you can see that there are quite a number of lesions in this particular patient that were not even identified on the 3D scan imaging. So I will say that it's really important for us to have a dedicated tech ahead of treating a patient. It also offers a lot more sensitivity. There's 100 times more affinity for the SSPR2, the target, as compared to a scan. And this will really help predict the clinical response and things like that. So we really need to be mindful of that when we're thinking about the pre-therapy imaging for these patients. We definitely want to give all the patients the opportunity to have this very amazing therapy. So we basically do the imaging first, then we see good amount of uptake in the areas that we're concerned about, maybe even some that we didn't even know about. Then we can radiate all of those lesions from inside out, and that's the wonderful thing about diagnostics. And so the mutation 177 is a critical part of the time. And because of that particulate radiation, it's able to deposit its energy very locally and not damage a lot of other tissues, but just the ones that it's very close to. So let's talk a little bit about the NETTER-1 trial. So NETTER-1 included patients who were over 18 and had metastatic or locally advanced inoperable histologically proven neuroendocrine tumors. They had a grade 1 or 2 disease with Ki-67 levels that's being less than or equal to 20%. Progressive disease on uninterrupted fixed dose octreotide, a long-acting octreotide, and they were obviously somatostatin receptor positive, and they had a good sentinel status. It was a prospective international multi-center randomized compared control parallel group in 51 states. There was 36 sites in Europe and 15 in the United States. And then 116 patients were in the therapy group and 113 in the control group. These are just some of the United States sites, and you can see they're scattered widely across the country. So the study aims for to evaluate the efficacy and safety of Lutathera. Primary endpoint was progression-free survival, and the secondary endpoints were for PPP, OS, and PLO as well. So you'll see that the overall survival, quality of life, et cetera, were favorable things as well. So study design was this. Patients were treated 4 times, 4 administrations every 8 weeks with this, and then they had a 5-year follow-up. And this is a really impressive progression-free survival survival curve here versus control of the Lutathera patients. The trial was stopped because we still haven't really reached the endpoint, and now we can see that things look really, really positive for the Lutathera patients. And similarly, overall survival not as dramatic, but overall survival is also it's really wonderful. So let's go over some of the guidelines. Some of the guidelines that we use very closely in our discussions, conferences, and things like that are the National Comprehensive Cancer Network guidelines, which go over a lot of different types of malignancies. I'm sure you're aware. But they go over things in this particular instance. It's about neuroendocrine tumors and a few different items that we might want to be considering. So somatostatin receptor based imaging would be considered in the setting of metastatic disease. And this is something to kind of keep in mind when we're doing primary evaluation for these patients. And also, if we're looking at management of local regional advanced disease and things like that, we can see that there are need for somatostatin receptor-based imaging if the patient's clinically symptomatic or having clinical signs of progression. And that's all very wonderful and good. But particularly important if the patient is to be having therapy with PRRT. So we want to make sure that we're doing that. And I'm going to hide my video for just a moment so that you're able to see this, but we want to be able to also select patients for PRRT and restage patients after completion of PRRT. So this is from the Society of Nuclear Medicine guideline for or appropriate use criteria for dotatate tests, but it is nonetheless important in the discussion for who receives PRRT. So when we're starting a program from scratch, there's a few things that need to be done. And having been in a place with starting things from scratch, where I was in private practice a while back, we had a really important notice, something that we noticed that was very important. We really needed a lot of people who were ready to talk because this did not just touch nuclear medicine. This touched a lot of different specialties. We wanted to make sure that we were doing all of the right things. So we were mindful of that and had a lot of different people in the room, oncologists, oncology nursing staff, people from radiation safety. And in the U.S., there's a lot of issues with insurance and pre-authorization and such. And so that also was something that we wanted to make sure was captured in the group discussion. Of course, our technologists and staff were going to be, stepping up to do a lot more things than what they were used to, and of course, improvements in positions too. So this is actually going to be a little bit more even. So this planning committee discussing like where is the room for helping the patients that receive them and we have access to a bathroom and receiving a lot of fluid. Collaboration on therapy, discussions and tumor consultations. Patients are quite complex. And we need for additional options from our interventional colleagues. Sometimes that's something that we want to do a little bit more with. In addition, potential for expanding staffing was discussed because there's going to be more patients and with the expanding dawn of the diagnostic age in nuclear medicine, this is something that we have to be mindful of. We're going to be seeing a lot more patients and a lot more patients can benefit from these therapies. So we want to make sure that patients have access to this. And if we're having a very long backlog of scheduling delays and things like that, it's not going to be very positive for the patient and also for the referring doctors. So one of the things that was discussed is to consider a paradigm where there's a nurse navigator who is involved in coordinating a lot of these complicated scheduling things and laboratory results that need to be done within a certain time frame, et cetera, so that this can make sure that the patient has a smooth experience through the process. And I would say too that not all neuroendocrine tumor patients are created equal. So in our discussion of pre-therapy imaging and things like that, I would be remiss if I didn't mention that some patients need not just a gallium-68 or copper-64 dotatate scan, but perhaps also F18, FEG to better understand how this behavior of the tumor is. Is it going to be well treated with, the dotatate therapy? We can use something called a crane score to identify a little bit of the uptake characteristics. But if the patient has a more poorly differentiated disease, we may not be quite as helpful with dotatate. So there's some variable uptake in that setting. This is how Mayo does their PRRTs, and this is from a great review article that I referenced here, that you can kind of go and see what happens. So an order is placed, and there's things that are happening at the same time. You have patients getting their consult on telemedicine, which is kind of very handy during the pandemic. And also insurance pre-authorization and other things that are kind of happening in the background, so the patients don't have to wait. But after the consultation, they have a systematic checklist that's reviewed. The patient goes to tumor conferences, the patient is discussed. Additional consults will be done as needed, checks and lab results, etc. And then once everybody is comfortable, we for patient to approve the therapy, and ideally at a time also the insurance authorization, patient second, and then moving forward with therapy. The day prior to therapy is kind of a big day, because you want to make sure that you ordered the dose appropriately. There's no chance of be an unused dose and things like that. So we want to make sure that we've checked the patient's labs and ensure that the patient is feeling well and things like that. And of course, we want to make sure the patient has some radiation safety instructions daily. At the time of the consult, when we're discussing this, but if not, the day before therapy will be helpful so that they are able to make some arrangements. And then a consent is obtained. This is often done in person because some places are having difficulty with some of the online signature things, and it's not just the places where I have been, but I think there's some computer concerns and cybersecurity things that are in question. But basically, the consent is obtained on the day of therapy in many situations. And then we briefly review the findings of the day of therapy, and the therapy is often 5 days a week. And they may be different in different institutions in the United States. At Stanford, we usually do the therapies on 2 days during the week, and 2 days for PSMA therapy. Because the color of the lead cave is green for both of them, so we want to minimize the chance for misadministrations. But anyhow, it's going to be another thing that our society is working on to try to make that a little better. So a typical day of therapy looks like this. The patient has a pre-medication regimen where they have, we have nursing staff that is available and sets all of these items for us. We have an order set that is on the computer that we are, looking to sign and things like that. And then we get the amino acids running. And then once they have been running for the appropriate length of time, the amino acids are to protect the kidneys and limit some of the potential radiation goes to the kidneys. Then a slow IV infusion is given, and of course cannot ingest this as a bolus. And then we continue on the amino acids until that infusion is complete and some additional saline. So you can see that these patients are definitely going to be in need of a bathroom periodically during their stay there. And so this is usually done as an outpatient. We have 2 different methods that can be done. The gravity method is one method where we have a short and a longer needle, and that is a very effective method. Some places, like Stanford, we choose to use a very slow rate, and that can also be done. Of course, careful sort of rinsing or flushing of the vials is helpful to make sure that all of that, good, therapy is infused into the patient. So some take-home medications are often given to the patient, and that's helpful to mitigate some of the side effects. Take-home radiation precautions are also given, and these are important to discuss with the patient. I will refer you to the ECR as a practice parameter for mutation 177 repeat therapy. And you can see here there's also a list of things that are discussed. And also some information about trash that's generated by the patient. So when we want to stop or delay treatment, this is usually a very deliberate decision if this is the case. So we want to stop in setting of severe heart failure, where we don't want to be giving that much fluid to somebody. Pregnancy, of course, always is a consideration whenever we're giving anything radioactive. So we would stop at that point if the patient did become pregnant. And then hypersensitivity. Of course, we don't want to expose the patient to somebody that to something that may make them allergic. We delay the therapy a lot of times if the patient's having some other medical problems, if they develop pneumonia or even COVID or other things like that, or they're having some cytopenias, we may wait for the bone marrow to recover a bit. We'll work closely with our oncology colleagues to see what, if any, infusions or transfusions they may need. So we are careful about patient selection. We talked a little bit about how not all of the tumors are created equal. The pathology will help drive some of this, but of course, it does not replace a PET scan before therapy so that we're able to assess that definitely there is uptake of that the somatostatin analog into that somatostatin receptor. And then the package insert, so the indication is for somatostatin receptor positive gastroenteropancreatic neuroendocrine tumors. I will say that there have been some instances where this has been used off-label, so keep that in mind that is a possible thing for the future. And certainly there's a lot of ongoing work in that area. It doesn't list any typical contraindications, although we wouldn't treat somebody who's pregnant and doesn't meet the criteria for the laboratory analysis ahead of time. There's a lot of precautions and warnings, things like myelosuppression, renal toxicity, and hepatic toxicity, and neuroendocrine hormonal crisis, which is rare, but we need to talk about. Patient evaluation is done ahead of time. We need to assess their hepatic function and renal function and their bone marrow function, because all of these areas can be impacted by the therapy, and we want to make sure the patient has some reserve. So side effects and adverse events. We see that a lot of patients who receive this therapy have improvement in some of their symptoms. And so this is their global health status. A lot of them improve their quality of life. Many patients had improvement in their diarrhea and flushing and pain. And this is just so that you're able to see a whole list of the different types of side effects that patients develop during the course of the metabolic trial. And the patients did have a number of things. Of course, nausea and vomiting was the most common. I will say that since we have changed the makeup of the amino acids, that nausea has improved quite a good deal. So that is wonderful. But still, we want to make sure that the patients are feeling okay. And so we always give them some pre-therapy, anti-nausea medicine, and things like that. So for nausea and vomiting, we just mentioned that. For the hormonal crisis, this is the one that I wanted to spend just a touch of time on. Because the hormonal crisis is not common, but it is definitely something that can cause the patient to have a need for an ICU bed acutely. So we want to make sure that this is occurring, we're watching and available, and this is another reason why during the infusion we need nursing support. So the release of hormones related to neuroendocrine tumors can lead to this symptom. The types of symptoms that you might see are flushing and diarrhea, hypotension, and bronchoconstriction. They don't all have to be present, and they can also occur 24 to 48 hours after treatment. So we want patients to be aware to be monitoring for these types of things. And the neuroendocrine hormonal crisis is rare. So it's about 1% of patients that might develop this, but it's something that always kind of needs to be worked on. In our practice, we've found that patients who are at baseline more symptomatic are at a little higher risk for hormonal crisis. So if patients do develop this hormonal crisis, it's very important to have on hand sandostatin so that you can get it to acutely We don't want to be, really getting this, but definitely getting this if it is a problem. If the patient is developing symptoms of a hormonal crisis, with the hypotension, et cetera. So in addition to sambastatin for hypotension, we would also want to be getting IV fluids, high-dose steroids to mitigate some of the inflammation and other things. And we want to check labs and such and see if the patient needs additional electrolytes, et cetera. But the thing that's going to reverse the symptoms the quickest is going to be that sambastatin. So that's important. So at the time of consultation, we usually talk to the patients and ask them if they're having these sorts of symptoms. There was one patient who has had these during my time at Emory. They were symptomatic prior to therapy. They did require intensive care, but they're now doing well and they had no additional episodes on subsequent therapy. So I will stop my video again here so that you can kind of get a look at this. And if you would like, I'm happy to share this with anyone. But there's some types of things that don't work quite as well as far as the medications go. So when I was at Emory, one of our residents and I worked on this, creating sort of a crash box, if you will, instead of a cart that had a lot of other items in it. From just your standard crush cart, but having the sambastatin available, IV fluids and dexamethasone and other things like that probably are going to be easier. But the bronchoconstriction is going to be a little bit different than what we're used to. Instead of getting albuterol, nebulized ipratropium or antihistamines would be a better choice. And we want to make sure that this may also depend on the type of tumor type the patient has. So if they have a gastroenteroma, we want to be thinking about pantoprazole and other things like that. So some other things that we think of very commonly when we think of a crash cart situation, we want our sympathomimetics and things like that. We want to avoid them in this setting because they can actually make things worse. So norepinephrine or epinephrine or morphine or albuterol can actually worsen the patient's symptoms and things like that. So we want to be careful in this setting. I'm happy to share this and other information with other individuals if that's desired in the future. But we'll keep going here. So take home points. We talked about the diagnostic principle. We talked about some guidelines. We talked about patient consideration, getting things off the ground with the new program, some side effects, the survival benefit, which is really the beautiful thing about this treatment, and the importance of a multidisciplinary approach. It's been a pleasure to see you all today virtually, but we wish you all a great conference and I will also give a quick
Thank you. Thank you. Thank you, Dr. Aaron. This was excellent. And we do wish we had you here. It would have been wonderful, absolutely. So we're going to switch gears here. We're going to have a little panel discussion. And for the panel, I'd like to invite our experts. Can we sit here? So we have Dr. Akhtar, Dr. Kulthum, clinical oncologist here at Khanum, Dr. Saima Muzahir. For this portion, well, we'll just add some chairs and we'll have you with us. For this portion, we'll have presentations of cases by our senior instructors, Dr. Sadat Mufti and Dr. Myra Razi. We're going to take you through a spectrum where, as we know, nuclear medicine progressed from basic imaging, we call it basic now, but it used to be Ocular scans and MITs, and we go towards gallium imaging and subsequently therapy. I think you've had such a wonderful presentation. We'll still hold questions. We need about 10 minutes at the end because we'd like to have a meaningful discussion in the end. So can I invite our panelists to come join us here?
Assalamualaikum and good morning, everyone. I'm glad to see you all here at this very first Shaukat Symposium. So, thank you, Dr. Amma, for this opportunity to present our cases at this forum. And so, I will be presenting findings of 1868 scans, case-based presentation. So I will be presenting the 1868 data scans. So the first case is a 20-year-old male who presented with headache and hypertension. His blood pressure was reported to be 150 by 90. So typical presentation of young patients and typical symptoms of headache and hypertension. So the first sign of workup was CT scan considered, which showed the left anterior renal tumor in contact with the left adrenal gland, and features were suggestive of pheochromocytoma. His metanephrine was normal. His normetanephrine was raised about 12:36, and in view of all these findings, NIPT scan was advised. So this is a planner image, and you can see biological distribution of the radio tracer, in which you can appreciate slightly gland uptake and liver uptake, and very faint uptake in the left renal left adrenal gland. And we did a SPECT CT over here, which shows large left adrenal soft tissue density. Part of it is necrosis, and there is peripheral river uptake medially. So the degree of uptake is very low on the NIPT scan. So there are scans and there are cases which can show significant uptake of NIPT scan. And so the plan was left adrenalectomy done in March 2019, and histopathology confirmed the diagnosis of pheochromocytoma. His post-op levels of normetanephrine were declined to 457, and then again in this patient had nodal disease recurrence on CT in 2021, and again the metanephrine started to rise to 33. Though in normal range, and the normetanephrine was again rising, showing rising trend, and it was about more than 800. So getting 68 DOTA PET scan was advised. This is a maximum intensity projection image, which showed normal distribution of the tracer with mild degree of uptake in the thyroid gland, pituitary gland, and intense activity in the liver. And here you can appreciate abnormal activity in the most likely in the region of left adrenal gland. And it has recurrence in the paraortic node. So this is on axial PET-CT images confirmed to be the paraortic nodal recurrence, and this is showing the significantly avid DOTA-avid nodal recurrence. So on the PET-CT, as compared to MIT scan, we can quantify the activity of the disease, and the SUV was about 8 in this patient. So the multidisciplinary decision was taken, and surgical resection was advised. Dr. Amma. I've actually decided that I involve our panel from here because it's going to be. So our first case, as Dr. Myra has presented, is actually something that we've over time come to now, and we're fortunate that Gallium 68 is here. But I would like to direct my question towards Dr. Akhtar. Dr. Akhtar, in your experience in the era when MITT was fully present, if you could comment on the sensitivities of pheochromocytoma for MITT that to Galvin's experience, sensitivities and specificities.
Well, I would say maybe still the poor man's choice. Those who can afford the luxury of wedding. I don't think there are many comparative studies that have sensitivity in humanity and studies have been published for obvious and humanity and the numbers, the maximum number is one study for 97. That study again, they used I think 1 to 3 and I think the special resolution is a bad factor and the sensitivity that they reported in that for customer that for availability is from 50 to 70. That is on patient to patient basis. But if you go to on median basis, the sensitivity for some, I think there was only one is 27%. So yes, median probability is more sensitive, but
So real world scenarios and real world situations, while Galvin is available in select centers, but absolutely. Dr. Simon, your experience, your center has MIBG completely phased out, or are you still performing it in some patients?
No, at MD we have been fortunate that we have been using MIBG for pheochromocytomas and paragangliomas, but since now we have lutetium based database therapies, which are very neat therapies, easy to administer, as you noticed in Dr. Brady's discussion, it's an IV administration, less radiation precautions compared to I1G1, which is very cumbersome, which requires hospitalization for a couple of days. So it's kind of lutetium database is kind of taking over, but it's a very interesting study, and NCCN guidelines also recommend off-label use of lutetium database therapy in those patients, especially where the expression of somatostatin receptors is higher than the MIBG uptake. So it's again, moving towards personalized medicine. But as and then the other thing is one of the questions that you would encounter, as Gallium-68 database is available here at SKM is your surgeons or oncologists calling, okay, I have a head and neck paraganglioma. What do you want me to do? I want to run MIBG versus database PET-CT. The correct answer is database PET-CT because the head and neck paragangiomas are parasympathetic in origin, where the sensitivity and specificity of database is superior to MIBG. So it's just tailoring according to the needs and demands.
Okay, Simon, go ahead.
Just one concern as a medical pathologist, I assume the patient is doing well now because that mass is removed and she was on surveillance.
Please, Dr. Myra, what is the update of the patient? Yeah. So the section was advised to patient lost to follow up, and now we're done with a couple of months back, so now I think 30 days later. Okay. So must be doing well. What is that?
And again, this is a real world scenario.
This is
also
it.
going on.
Yes, most of the discussions we have, we look at the ideal situation, but they will like. Dr. Simon, any now this is just outside the box. Any patients who have tried I131 MIBG and then gone on to nutrition therapy? Any data at all?
I'm not aware of that, and since lutetium database has been out there since 2018, initially people have been focused on treating only the neuroendocrine tumors. But again, as I said, there is data on the off-label use of lutetium database, and we have actually treated patients with recurrent paragangiomas at MD with that, but then those patients never got the MIBG. And in our patient, again, the scenario was exactly what you presented.
We did both MIBG diagnostic scan and rotaplate, and because of the tumor heterogeneity, the rotaplate, the lesions were more avid compared to the MIBG, and we decided to move forward, giving the rotaplate therapy, lutetium rotaplate therapy. One of the things is, insurance is a big thing in the United States, so a lot of things are kind of constrained, or it's an off-label use, but now because NCCN guidelines are also endorsing it, so you know, the payers don't give us a hard time, but that's one of the things that we do off track or tandem them that the patient got MIBG. MIBG therapy is not routinely performed in very many places in the United States. Again, it needs a whole setup. And most of these patients are invariably hospitalized for at least 3 to 4 days with strict radiation precautions, and your RSO is involved and all that. And we are offering MIBG therapy for our pediatric population at Showa Children's Hospital of Atlanta.
Dr. Akhtar, any experience in Pakistan with I-131 MIBG therapy?
Not for me personally, but I think there are scientists, especially if there's been there.
Dr. Mathurson, any comment on prognosis for these patients?
Mediator's disease, 67% less than 20%. So if they have relapse and metastatic disease, and if that is resected, then the disease-free survival is really good, around more than 50%, 5-year survival. But if it is metastatic and it is not resectable, and if it is a liver met, the liver-directed therapy cannot be done, then the figures they come down, and then they need systemic therapy. And depending on where they are and what they look for, and there is a list of things that we can offer.
We move on to the next one. Dr. Archie, you have comment?
Yeah, I just needed to ask one question.
In the case of pediatric patients, how do you distinguish the uptake in the every exam? Because you know there's normal physiological case of uptake as well. And the CT findings are also not that helpful. So do you go for some other radiopharmaceutical like DOPA?
DOPA is not routinely performed, but I understand that with the rotaplate vaccine, you see very symmetric prominent uptake in the elements. But usually if something is more asymmetric and more intense uptake, if it's symmetric, then there's no radiologic abnormality, then yeah, it's hard.
Because this is a problem that you see in our pediatric patients a number of times.
Yeah, it's only if the uptake is at least 2 times higher than the contralateral.
But sometimes it's present in both, when it's symmetrical, it's increased, and the CT is not helping you. Because in Portugal, I happen to see that they would go for, DOPA of the hereditary tumors in pediatric patients.
Yeah, that could be incorporated. I don't have experience with that, and MR imaging without contrast can also help.
And one question from Dr. Akhtar, you were saying that in case of MIBG imaging, in the case of the patient sensitivity is much better than lesion sensitivity. I really not, I'm a little confused about it because you quoted a figure of around 70%, which I believe is a bit high, looking at the images and the sort of resolution that you have for MIBG.
In one patient, you get multiple lesions. You see all the lesions. Maybe you see less number of lesions, so that patient is positive on MIBG, but the number of lesions, I don't remember exactly. It was something like 400 lesions were seen on Thursday, and when we compared it with MIBG, it was 24. So the number of patients were so like in one patient you can see multiple lesions.
That is something I totally agree with because these two imaging modalities, KDPS and KDPS, they really act like an adequate. Because, you can pick up lymph nodes even a few millimeters in size, 3 to 4 millimeters in size, and they shine out on the images when you do the endothelium or PSMA or BAD.
The advantage, the quantification also, the quantification. I remember when we are doing ocular scans, just right, they need to quantify the liver lesions pre and post. So with the data, we can ideally without that.
People do use the, we are all familiar with the training score that we used to have with lithium. With the Gallium 68 dotted PET CD, now we call something which is a modified training score, which ACR endorses, where you use spleen or kidney as your reference. So anything higher than spleen or kidney is can be modified training score. And the higher the training score is, the more likely that these patients will benefit from targeted therapy.
Thank you, Dr. Saima. We will really come to that and then come to yourself. Thank you. So I'll move on to the next case. So this patient is a 62 years female patient who presented with epigastric pain, nausea, and vomiting. Her endoscopy revealed extensive compression in the distal ankle. And the CT scan was done, which showed exophytic mass arising from the gastric antrum and pylorus, and it seems inseparable from the pancreatic head. Histopathological correlation was done, and biopsy showed the well-differentiated neuroendocrine tumor grade 1. So of his, her operative scan was done in 2017, which showed. So these are planar images at 20 minutes and 4 hours, and here you can appreciate homogeneous uptake in the liver and the spleen, and the normal urinary excretion of the retrograde via kidneys and the bladder activity. And there is an abnormal activity in the right and the abdomen. And on the 20 minutes image as well as 4-hour image, where the background in the kidneys has shown more clearance and the veins become more prominent at 4 hours too. So this correlates with the CT scan finding of large extensive mass compressing the gastroduodenal mass. Unfortunately, disease was irresectable, and the patient had gone palliative gastrostomy followed by radiotherapy. And then he was started on sandostatin long-acting release monthly, followed by everolimus for some time. And then follow-up scan with gallium reductive PET-CT was advised in March 2020. So this is a maximum intensity projection image, which is showing intense the DOTA-avid tumor. Here on the axial images, you can appreciate abnormal soft tissue with intensely DOTA avidity, and the avidity goes up to 77 SUV in this case. So the currently patient is having low off and on bleeding, which requires intervention at some time, and now he's on occupied therapy monthly. So this is the case of occupied scan versus bleeding without fake activity. Now I'll move on to the next case. So this is a patient with 48 years who presented with progressive weight loss, vomiting, and mild epigastric pain. His CT abdomen and pelvis done, which showed a pancreatic head mass involving small bowel with retroperitoneal lymphadenopathy and hepatic metastasis. So his diagnosis was neuroendocrine tumor low-grade from the ultrasound guided liver biopsy, and it was turned out to be metastatic. His baseline DOTA scan was done at the outside facility and images were not available, but the report mentioned that the pancreatic head mass was DOTA avid, and there was no abnormal uptake, DOTA uptake in the liver lesions. So on the basis of DOTA ability in the pancreatic head mass, the patient was started on the octreotide therapy. Later on, the disease progressed in December 2020 on the CT scan, and the patient was switched to chemotherapy. The CT scan in January revealed stable pancreatic mass and periodic nodes, and the hepatic nets, there were multiple diffuse metastasis, which showed internal necrosis. So again, PET-CT, DOTA PET-CT was done in this patient. These X-ray images at the level of the pancreatic head shows intense abnormal uptake in the pancreatic head mass, and the SUV was 8.6. And there are a few nodes, retroperitoneal nodes, and this is the renal activity. And the next image shows liver lesions. So here you can appreciate a large hepatic lesion with which is predominantly necrotic. A part of it is very solid, but this again is not showing intense ability on the DOTA scan. So after now, the patient has received total 20 cycles of chemotherapy, and we again considered DOTA PET-CT in this patient. So on this final images, here you can appreciate the degree of ability in the pancreatic head mass. And here you can appreciate the large hepatic vein which appears necrotic and proton deficient. So there was no uptake in the liver veins. And the X-ray images shows residual activity in the pancreatic head mass. So SUV was decreased from 8.0 to 5.3 in this case. So again, I'll directly look down
For our panel. So can I ask the question? Yes, please, sorry. So I want to ask from Saima and from Dr. So this patient had a biopsy from the liver region, and it was grade 1. Yeah. And what was the reason that this was total negative at that time? I mean, the pancreatic region was highlighting, it was habit on the scan, but not the liver. Although it was also a low grade.
She said that was the necrotic issue because to all metabolic imaging, you have to have a viable tissue. Absolutely. Whenever there is a necrosis, functional tissue, it's the functional. So whatever functions was there, can these are those candidates these and you can go in this second patient. Now you go upfront with patients that are recurrence also.
Exactly as Dr. Axel very rightly mentioned, that anything necrotic, of course, won't wake up. The other thing which we struggle and we face the challenge is tumor heterogeneity. And the tumor, and even if the primary is very somatostatin receptor expressing positive, the metastases might not. And in this particular case, I would also like to do an FTT PET to see the net PET score and see that will provide you more insight about the tumor biology. And if the things are more FTT added, then that means that this is a more aggressive tumor.
So that is the plan for the patient. Now, in your experience, let's hypothetically assume that positive, peripherally at least they have a significant. Would you proceed towards
That's what the data shows and the literature shows, that you still give the benefit of doubt to these patients, especially if they are, the chronic score is at least 3. I won't do it if it's a modified chronic score 2. Those patients don't do well, but since the lesions are quite intensely lighting up, even if they do show up uptake on the FDP, some of the lesions, or I would still go ahead and treat.
Would you re-biopsy these patients when you have rapid progression like that?
Exactly, that's very true. Yeah, we need to, again, because of the tumor heterogeneity and tumor biology, it changes.
It may change the therapy.
Exactly.
Thank you. Now I request Dr. Siddharth to continue the presentation.
So I'm going to need to cases case and scan the discussion is still done on the therapeutic aspect, such as the case is showing some typical indications and findings. So my first patient is 68 years old male with a neomarginal prostate, given score of 5, a high risk, PSA levels to 29. Recent workup was done with CT scan of the chest and abdomen, which was unremarkable for any visitor or office metastasis. Initial MRI valves was done to look at the evaluation, T3D, and when received the status 5. Lymph nodes and visualized bones were returned into water. Bone scan was also unremarkable. This is similar to the bone scan, planar image, showing quite symmetrical space and update without any obvious focal abnormalities suggesting metastasis. So initial discussion was done in the MDT after this workup, and radiation therapy was advised for non-metastatic disease. There was some time in starting the radiotherapy. Meanwhile, the patient was started on the treatment, and PSA PET scan was also advised at that time, considering the high risk of the disease. So here is the radium 68 PSA PET scan, maximum intensity projection image showing. So this is showing the activity within the prostate gland for average is compared to the liver activity. In addition to this, there are lymph nodes, pelvic size wall, which were also shown on the MRI of the pelvis. These are showing this PSA ability. In addition to this, there is a focal uptake in the right side of the sacrum. Unfortunately, I was unable to look at the bone windows. On the bone windows of the CT scan, there is underlying lytic lesion with some southern sclerosis in the periphery, and this is characterized as the metastatic bone lesion. In addition, these were the small lymph nodes in the left common iliac region, which were not significant by the size criteria on the CT scan. However, they are significant PSA average, and these are also involved by the metastatic disease. So, based upon the PSMA findings, it was upstaged with oligometastasis in the bone. Radiation therapy was deferred, and LHRH was continued along with the Zoleta.
Dr. Sam, a question here for you. Any experience using INRT instead of the gallium PSMA 617? Currently, we do have some issues in availability for that. Any experience?
No, unfortunately, I do not have experience in INRT, but I was recently at the EN, and there are a lot of people, your listeners have a lot of experience with INRT.
And I think with the current scenario, perhaps more and more centers will
move towards that. Yeah, even in US at MD, like once this got FDA approved in March this year, there's a lot of demand and the Novartis is not able to take place with it.
Right.
And when I talked to the Novartis representative, what they said the plan is, so they have the manufacturing line in Europe and they are shipping to US, and the doses that they plan to deliver are the same number of doses that they're doing for neuroendocrine tumors, which doesn't make sense. The neuroendocrine tumors are like rare tumors compared to prostate. So there's each day I get emails from all the urologists. Can you put this patient as that?
So that is the scenario we're facing here as well, the function shortage. And if I can ask Dr. Arthur, any experience on your end?
Yes, we are using previously 617. And I believe right now as well.
Mike. Yes, we have like more than 150 patients now, including both, prostate as well as neuroendocrine tumors. And we were using 617 previously. And what we're using right now, I'm not really sure, but I can explain you the feedback after discussing with our radiochemist.
And one of the things I would like to point out to Dr. Murthy's case is regarding the oligometastatic disease, few nodes lighting up in the bone. So if you would make a debate in an MDC, would this patient would qualify for lutetium PSMA therapy? People would argue against it. They say with oligometastatic disease, probably EBRT and hormone therapy should be started first before jumping onto the PSMA.
Yeah,
I also would think that I would biopsy that sacral lesion because it's easily accessible. Because you are changing the whole treatment scenario in this patient. So I would consider biopsy. So
as you mentioned, tissue diagnosis is always the gold standard, but sometimes there are scenarios where it's not feasible or, the patient is not willing and all that. And that's why I think these neuroimaging diagnostic agents are acting as biomarkers and kind of providing an overview of rather than doing biopsy of each of the lesions. But definitely there are few lesions that you would like to know more about tumor biology of this.
I think one of the most exciting things that we've seen routinely is the smallest node. I think it's more of a threshold. Is it going to be a 1 millimeter or 2 millimeter or 2 millimeter?
Is it that, are we learning more or, oncologists, they're always questioning maybe the disease was always there and we didn't know and
In the interest of time, we'll move on forward. There's a very short.
So there is another case, 70-year-old male patient with adenocarcinoma of prostate, significantly raised PSA levels of more than 230. So in this patient, PSA PET CT scan was able to show extensive locally advanced disease and the prostate that is invading bladder wall, additionally nodal disease and pelvis and nodal disease at the mediastinum. So as we have already had a great discussion regarding this, even PSMA scans can help in selecting the patients for the right therapeutic strategy. By early detection of the disease, they detect the progressive and active lesions and post-prostatectomy patients under reevaluation. And another advantage is here in assessing the PSMA expression before planning the radioligand therapy. So my next case is more like an interesting image with an incidental finding in addition to the prostate. A 68-year-old male presented with urinary symptoms, enlarged prostate on the ultrasound, significantly high PSA levels of 128. Prostate biopsy confirmed the adenocarcinoma lesion score 9. So CT chest abdomen pelvis revealed the primary findings in the enlarged prostate. Liver was a bit coarse with focal hypertension in segment 6/7. Bone scan was negative, and his baseline PSMA PET CT scan was advised. for the further workup. They're looking pretty good with symmetrical uptick on the planar bone images. However, on PSMA PET CT scan, this is the maximum intensity projection image showing the uptick in the frontal bone. There is this uptick in the liver region and then in the prostate. So upon the axial images, there is this frontal lobe region showing PSMA uptick. Liver region well appreciated of the CT component with raised SUV value and the primary prostate. All these SUVs were more than the basic reference SUVs. We advanced further evaluation with MRI brain and MRI abdomen before labeling it metastatic disease. MRI brain revealed features suggestive of frontal meningioma on the right side. Similarly, MR abdomen showed early cirrhotic changes with single focus of hepatocellular carcinoma in the secondary cell of the liver. So he was continued with the therapy for the prostate, including the local radiation followed by LHRH agonist. Side by side, he had resection of this hepatocellular carcinoma. It was the solitary lesion and non-metastatic, and post-operative imaging were unremarkable for any recurrent disease in the liver. And stereotactic radiotherapy was given for the meningioma. So incidental finding of additional lesions with good treatment in this patient. Another case where an incidental finding was seen on the PSMA PET CT scan, 69 years old male with adenocarcinoma prostate, lesion 4+5. He had radical prostatectomy, osseous metastasis were there in baseline imaging. He was started on the therapy. Slowly rising PSA levels despite leukerin. So PSMA PET CT scan was advised for the admission. So this is the PET CT scan. This showed these osseous lesions which were significantly added. In addition to this, there was this soft tissue bleeding along the lower pole of the left kidney, which was not showing any PSMA activity. So patient had left nephrectomy after discussion in the multidisciplinary imaging and histopathology for the renal cell carcinoma and the proper complete dissection of the tumor and therapy for the prostate cancer is going on. So it is important to see the additional findings on the PET CT scan, which can be non-evident, still visible on the list. So just this last case, and we're actually out of time. Otherwise, we had a couple more exciting cases. But I would like our panel to comment about the incidental findings for we're all seeing them as well. And also exciting findings incidental ones. Especially the meningioma, we are seeing those frequently on the in a particular location, especially on the even on the lower lake where to give you an idea. It looks actually, the appearance even on the other hand, CT is very suggestive of meningioma. And then what are the odds of prostate cancer going on the uterus?
Any comment on HCC? Another exciting therapy. And
yeah, this is something there's something new to look at and HCC lighting upon us. How much was
it's gone to case report, right? So we went to literature, so it's mentioning one or two case reports where update was seen in the HCC.
And one of the things that I noticed, and I being very busy and publishing on that, is a splenic hematoma is like a there was a one case that we had in the GI tumor board, and there was very intense uptake in the spleen. Although spleen already is very intense, but that thing was shining like a light bulb. And on the CT, you could see, some. There was an MR where you could see an enhancing lesion here, and that was biopsy, and it was marked. And there is not very much cases happening.
So exciting frontiers were at times actually looking to image HCC also because of the data that we've seen
HCC imaging and HCC is so present in this area?
This is something very interesting that I've recently come across, and one of my colleagues told me that they're using system ED to image renal tumors, and then they're comparing, I think, I will share that with you and to identify high risk and carcinomas. And it's a very simple planar inspect CT imaging, and it's
It's worth trying.
yeah, and it's very straightforward. That's where we started doing that.
So the non-specific tumor marker is given maybe. So I think if we can give a couple of minutes, if anyone from the audience has any questions, come forward.
Correction, please. I think it's not needy. It's I'm blanking on it. I think it's some of the surprise. Yeah. Yeah. Pardon because of my growing age. But I shared with you guys, yeah, and I was amazed, and yeah, we started doing it.
I mean, maybe it has a defined role, but maybe something else.
So one comment, this emphasizes the importance of multidisciplinary medicine. I mean, if this is the report that something is lighting up at frontal area and there is a huge metastasis so-called in the liver, that patient would have been outrightly, there was a metastatic disease and treated as such. So when 3 or 4 people, they sit together and they think out of box and do extra investigations, only then you can save the patient, you can treat all those synchronous primaries and the non-malignant tumors, and the patient's prognosis depends on this. It's not just the investigation, it's study. So this emphasizes how important it is for us to sit together and talk about it.
Absolutely.
It was an interesting.
Dr. Brady just texted and she is very much interested. She thought that she might chime in if she can.
Are we able to get a Zoom comment? Special thanks to Dr. Brady for being here. I know it's an ungodly time of the day of the night for you. We're going to try and if we can take you on.
कमेंट किया उन्होंने वो ज्वाइन कर सकते हैं ज्वाइन कर सकते हैं उनके पास जी ऑडिबल एज ए पैनलिस्ट ज्वाइन
Excellent. Give it a try.
I'm sorry, I'm having a lot of trouble hearing. Are you guys trying to ask me a question?
Yes, we can hear you.
Oh, good, wonderful. Okay. So what's the question? I'm having a lot of trouble hearing. There's been some background noise.
I thought, Aaron, that you wanted to chime in on one of the cases or share your experience.
I'm hearing a lot of other folks speaking at the same time on my end. So I'm unfortunately not able to hear very well. I apologize. Say it one more time for me, please.
I don't think so. I think there's some technical issues. Most of the audience here are not speaking at all. So I don't know where you're getting this background noise. What I wanted to say is, do you have to chime in on the cases that were presented today? What is your take on? I'll text you on what.
Yeah, I'm happy to chime in offline. It's been really, really hard. I think there's been some other comments about cannot hear the discussion clearly and things like that, but it's definitely been, from what I have been able to gather, very interesting cases, and I'm really grateful for the opportunity to spend time with you all today.
Thank you. Thank you. We appreciate your presence and for the talk you've given us. If there are no more questions from the audience, there is a question, please. Excellent presentation from everyone here. I have a question. As you know that it's far better than FTP density.
Can we consider FDG density as a follow-up scanning of patients who have already progressed in their course of treatment and they are already a high-risk patient? Can we switch to FDG density mainly due to logistic reasons or the cost we have in our part of the world? Can we switch from PSMA PET-CT to FDG as serial imaging using follow-up?
So I guess the question is, if someone's progressing rapidly, can we take that as a surrogate that the patient is actually probably poorly differentiated now, and in case instead of gallium PSMA, which is more expensive than FDG, can we switch?
Actually, as we do the DOTA gauge, when the tumor is not well differentiated, it is poorly differentiated, so there is not much data for giving 68 DOTA. So is this
no, I mean your question. Thank you for your question. It's a very interesting question and a real life, situation that we encounter, especially with the logistic issues. And it does make sense if the tumor is clinically you think it's an aggressive tumor. So as replacing PSMA with FDG might be helpful because if the lesions are lighting up, they will provide you some biological insight into the tumor biology, right? That it's an aggressive tumor. But FDG and PSMA in itself, each of them have their own merits, right? And even in the metastatic CRPC, which is an aggressive domain or the advanced stage, the PSMA expression they are overexpressed. The PSMA receptors are overexpressed in cancer cells. So there is no right answer, but given the situation that you're telling, of course, you can go ahead and it's not like it's best to offer any functional imaging rather than offering nothing.
I'm sorry, I will have to conclude the session because of the time. This has been so exciting. I can foresee another hour-long discussion easily. Thank you very much to our speakers, our panelists, our audience online. I really appreciate everyone's presence, our audience on site. Thank you very much. Our speakers will be here for a little bit. We can mingle outside. Thank you very much, everyone.